Okay, we are ready for the discussion. We have, I think, 10 minutes before coffee break. Happy face now, yes. I want just to start with the first question is to Dr. Brand, if you use neuronavigation, or because I like to use neuronavigation during endoscopic procedures. I think it's better to have. Why not? Dr. Brand, yes. About neuronavigation, if
I
you
think
use
neuronavigation we use in all those cases.
Okay.
But we really had sometimes also a mismatch. So we really like to check the neuronavigation before we enter the dura to reassure we are right. And in some cases, we actually see that sometimes there can also be a problem in the neuronavigation. So I think it's a really good point, but it's always good to have the anatomy well established, and then you can match your navigation before you enter the dura.
CT scan and MRI, both, or just one? Just MRI?
Well, actually, mostly it's the MRI.
Yes, because
so
CT sometimes is...
study now to see whether or not a CT scan is actually necessary or not.
Okay.
But usually it's the MRI.
Okay, thank you very much. Please, other questions?
But the lectures were superb, all of them wonderful. I want to talk to Shelley about the second pituitary stalk. What is the imaging ability to differentiate between Langerhans cell histiocytosis and a germ cell tumor? How far can we go with imaging on that pathology?
We can't. I don't think we can be that specific. I think we look at the digital. Germ cell tumor is actually more common, depending on gender, but it could be in the pineal region. You usually have a larger mass. Can be more heterogeneous. So in the case that I showed here specifically, I would go more actually for other granulomatous, like lymphocytic hyperphagocytes, other granulomatous disease, and not so much to a germ cell tumor. But then again, sometimes if you catch it very early for any kind of reason, then it still can be a germ cell tumor.
Yeah, I also wanted to ask you, so the ectopic gland and the ectopic adenomyophysis, is this related with neurohypophysis? Is it related with a dysfunction, or is it just an anatomical variant?
No, it is usually related to some dysfunction.
Yeah.
That can differ from severe dysfunction to maybe moderate, but it won't be associated with dysfunction.
And if I can also, very interesting, your concern about gadolinium. And most of the places, as you say, the radiologist will not sit at the MRI during the study and decide, right? And so it's going to be protocols. What do you think, what kind of maybe endogenous contrast maybe will be used in the future? Will new MRI techniques, higher field, maybe lower field, give us the possibility to just use endogenous tissue characteristics more than gadolinium?
So first of all, I think people are all the time trying to find additional contrast. This is not yet visible clinically, and I don't see it in the near future. Mm-hmm. I do think we'll see more and more works going to very specific clinical indications and pathologies to show when you need to give contrast and when you don't. And I would say that actually, in my opinion, for children that are not sedated, it's not terrible to start with a non-contrast study. And if you see something that you want to reject, you can bring the child again. Of course, our most concern is we sedate a child for the study. And that's where I really recommend that there will be somebody online to visualize that study and look at it and decide if to give the contrast or not. So what I see coming up is just more and more studies trying to help us guideline our protocols.
Thanks.
Other questions? Okay, I think
we
we
have
are...
the resolution of Oliver's image Where is Dr. Bosinov?
Yeah.
What do you mean?
Well, you didn't give us the answer.
That's right. It was a medulloblastoma, of course.
Ah.
If you don't know what it is, it's always a medulloblastoma. That's my opinion.
You can close the first section and